Is stream.
Hello, everyone, and welcome to today's session. Physical fitness is the first requisite of the happiness. A very good morning to all of you. I, Disha Arjuna, and I, Shiny Christy, welcome you all for today's session. As you all aware that we are celebrating World Diabetes Day, so we proceed in our next session. Diabetes is a very common disease in a world. Diabetes is a metabolic disorder which is identified by the high blood sugar level. Increased blood glucose level damage the vital organ as well as other organ of the human body that causing other potential health ailments. Diabetes is a serious life-threatening disease and must be constantly monitored and effectively subdued with a proper medication and by adapting a healthy lifestyle. By following a healthy lifestyle, regular checkup, and proper medication, we can observe a healthy and a long life.
A very good morning, all of you. I would like to request Ms. Nikita Johan to provide knowledge in nursing management of diabetes. She is nursing tutor in Sri G.H. Patel College of Nursing, Karamsar. She is working in this institute since 3 years. She had completed MSc Nursing and in Medical Surgical Nursing, and her subspecialty is Critical Care Nursing. We welcome you, madam. Now over to you, madam.
Uh, Very good morning to all. Today I will discuss on the topic assessment, nursing diagnosis and intervention in diabetic care. So first we will see the assessment of the diabetic patient. So first of all, we have to assess the patient's history. In that, symptoms of the diabetes, like patients having symptoms of hyperglycemia, like headache, fatigue, frequent urination. So these are the symptoms we have to assess. Then result of blood glucose monitoring. We have to check the fasting, then random blood sugar and PP2BS. Then adherence to prescribe the dietary management, then exercise and pharmacological management. We have to ask the patient whether the patient taking any kind of medication, right? So because sometimes some medication causes the high blood glucose level, like if the patient take steroid medication, so in that case the glucose level will increase automatically. Then patient's lifestyle, cultural, psychological and economical factor also affect the patient's diabetic level. Then also we have to assess the effect of diabetes on functional status should be performed. So these all the aspect we have to cover in the patient's history. Then second is to assess the physical condition. In that first we have to measure the blood pressure. because sometimes hypertension is associated disease with the diabetes. Then we also have to check the orthostatic hypertension. We have to check the blood pressure in sitting as well as the standing position. Then we also have to check the nervous system, because sometimes nervous system also affect in this condition. Then we also perform the examination of foot, skin and mouth. Then laboratory examination, in that we have to check the HbA1c level, that is glycated hemoglobin level, because it gives the exact value of the glucose level. Like it shows that last average 2 to 3 months of blood sugar level. So HbA1c, then fasting blood sugar, then lipid profile, then serum creatinine level, because in diabetes renal failure is the main complication. So we have to also check the creatinine level. Then urinalysis and ECG will be performed in the laboratory examination. So in assessment we have include this kind of all the aspects. Now, one by one, we will see the main nursing diagnosis which will observe in the diabetic patient. So, one by one, nursing diagnosis and the intervention for that particular diagnosis. So, first is risk for unstable blood glucose level related to patients may have insulin resistance. The insulin is not secreted properly, or the beta cell get destruction. So we have to check for the signs of hyperglycemia, right? So patients may have signs of fatigue, headache, frequent urination, increased thirst. So these are the signs of hyperglycemia that we have to assess. Then assess blood glucose level before meal and at bedtime. Then HbA1c level. Okay. Already we have seen HbA1c. So the normal level of HbA1c, that is less than 6%. Pre-diabetic, that is 6 to 6.4, and diabetes, that is greater than 6.5 percentage. Then assess for anxiety, tremors and slurring of speech. So these are the signs of hypoglycemia. So if the patient is having hypoglycemia, we have to treat with 50% dextrose. Assess feet for temperature, pulse, color and sensation, because sometimes patient may develop these kind of sign and symptoms. Then the other intervention include the we have to check the knowledge and understanding about the prescribed diet. Whatever the diet we have prescribed to the patient, we have to check the knowledge whether the patient understood that diet or not. If we written like that, you have to take the diabetic diet, but what kind of diet includes in diabetic diet, that also we have to that also we have to tell the patients. Then also we have to check that physical activity of the patient. Then signs of hypoglycemia, then glucose monitoring, that all the factors we have to check. Then next is report BP more than 160 mm of Hg, systolic BP. Because diabetes and hypertension may, if the patient having diabetes, so patient may have developing hypertension, because patient is at risk of developing hypertension. Then instruct the patient to avoid heating pad and always wear shoes. Okay, because in diabetes delay healing is seen. So we have to instruct the patient that do not go outside with barefoot, always wear shoes. Also we have advised the patient to wear white socks, right? Instruct the patient to take oral hypoglycemic agent like biguanide, sulfonylureas, So these are all the drugs that decrease the glucose production by the liver. Then instruct patient to take insulin as directed, because insulin is there are different type of insulin, that is short acting, then rapid acting, then intermediate acting. So these are the insulin we have to advise the patient that short acting, sorry, rapid acting insulin start their action within 30 minutes. Then short acting and intermediate acting insulin start their effect within 1 hour. Now next diagnosis, that is fatigue related to decreased metabolic energy production, altered body chemistry, insufficient insulin and increased energy demand. Increased energy demand, then hypermetabolic state. So ultimately patient may develop fatigue. So in that we have to discuss with the patient for need for activity, right? Then plan schedule with patient and identify activity that lead to fatigue. Means we have to identify that which activity can lead the patient to fatigue. Then monitor pulse, respiratory rate and BP before and after activity, so that ultimately we can get the idea, like such kind of exercise, in such kind of exercise patients pulse, respiratory rate and blood pressure get increased. Then we have to identify the ways of conserving energy while bathing, transferring and so on. Then participation in activities of daily living. Patient, we have to assist the patient and maximum activities performed by the patient. Then response to activity. If the patient perform any activities of daily living, then we have to ask the patient for the response of the activity, right? Then muscle strain, also we have to assess the whether the patient is able to perform that particular activity or not. Then need for activity, that also we have to assess. Okay. Then alternate activity with period of rest and uninterrupted sleep. Means uh, advise the patient that do not perform continuous activity, but uh, perform activity, then take rest, then again perform the other activity. Then provide adequate ventilation, then instruct the patient to take the deep breathing, and we have to ensure that provide the comfort and safety during the performing of activities of daily living. Then administer oxygen as order, because sometimes what happen if the patient is perform any kind of activity, so at that time after the performing of activity spo2 level may get decreased, so at that time we have to administer the oxygen. Now next is imbalanced nutrition meals and body requirement related to insulin deficiency or decreased oral intake or hypermetabolic state or any kind of infectious process. So we have to ascertain patient's dietary program and usual pattern, then compare with recent intake. Means likewise, patient is taking more diet, but due to the disease process, the intake of diet is decreased. So we have to compare the usual pattern of diet with the recent intake of diet. Then understand the nutritional needs of the patient. Means what kind of nutrition is more important for the patient, like patient having importance of taking the high protein diet or high high fiber diet, so that also we have to identify according to the patient condition. Discuss eating habit and encourage a diabetic diet. Also we always advise the patient to take a diabetic diet. We have to monitor the weight of the patient. We do not estimate the weight that the person is like this, looking like this. So actual weight is that like 60 or 70. We always measure the weight, actual weight. Then if the further requirement, then we have to consult the patient with the dietitian or physician. Then auscultate vowel sound, not report of abdominal pain, bloating, nausea, vomiting of undigested food. Okay, we also check the vowel sound for any kind of abnormality. Then provide liquid containing nutrient and electrolyte as soon as the patient can tolerate oral fluids, then progress to a portion. Yes, we have to advise that we patient have to take the maximum of oral fluids. Okay. Okay. Then observe for sign of hypoglycemia in that patient's level of consciousness will be changed. Then skin become cool and clammy, pulse is rapid, patient may feel the irritability, then anxiety, headache and shakiness. Then administer regular insulin, then administer glucose solution, right? If the patient's having hypoglycemia, so immediately administer the glucose solution. Now next is risk of infection related to delay healing of open wound. Because of in diabetes, the wound healing process get delayed. So patient may develop infection. So we have to observe the sign of infection like patient having fever or flush appearance or drainage from the wound, then cloudy urine and purulent sputum. So these are the signs of infection. Then we have to promote good hand hygiene to the patient. Maintain asepsis during IV insertion, administration of medication, and providing wound or site care. So, maintain aseptic technique because sometimes what happens, we do not maintain the aseptic technique, so patient may get infection through IV insertion. Provide catheter or perineal care. Then teach female patient to clean from back to front to back after elimination because these are the small points that may cause the infection to the patient. Then provide meticulous skin care in that gently massage bony areas. Then keep skin dry, keep linens dry and wrinkle free because these is also can cause the infection to the patient and may sometimes it can cause the bed sore also. Then auscultate the breath sound because if there is any infection in the lung, so ultimately it can identify through auscultation of the breath sound like abnormal breath sound like crackle, ronchi, pleural friction rub. So these are the abnormal breath sound. Then put the patient in a semi-fowler position. So it can provide the comfort to the patient. Encourage and assist with oral hygiene. Also, we have to encourage the patient to maintain proper oral hygiene. So these are the, and last one is administer antibiotic. Okay, if the infection is severe, so we have to administer the antibiotic. Then disturb sensory perception. So these are the risk patient may having due to diabetes. So in that case, vital sign and mental status, because sensory perception may be lost due to diabetes. Call the patient by name, reorient as needed to place, person and time. We have to call the patient by name, whether the patient is oriented to time, place or person. Short explanation we have to give the patient, then speak slowly and enunciate clearly. Properly we have to pronunciate with the patient. Then schedule and cluster nursing time and intervention. Properly we have to provide the intervention. Then keep patient's routine as consistent as possible. Encourage participation in activities of daily living as able. Then the other intervention in that, evaluate visual activity acuity as indicated. Means sometimes it can cause the uh, it can affect the visual activity of the patient. Then Then protect patient from injury by avoiding or limiting the use of restraint. Okay, because sometimes patient does not have any sensory perception, so patient may get injured. Then assist patient with ambulation or position changes. Then carry out prescribed regimen for correcting decay as indicated, because sometimes the diabetes complication is diabetic ketoacidosis. So in that case, patient may having disturbed sensory perception. So if the patient develop the decay, then immediately we have to treat the diabetic ketoacidosis. Risk for deficient fluid volume due to osmotic, diuretic, excessive gastric loss, diarrhea, vomiting and restricted intake. So in that, we have to identify the duration and intensity of symptoms such as vomiting, excessive urination. Okay, we have to ask the patient for the episode of vomiting. Then vital sign, in that orthostatic BP changes, then respiratory pattern and Kusuma's respiration, acetone breathe. So these are the symptoms. When the patient develop diabetic ketoacidosis, at that time patient having acetone breath and Kusuma's respiration. Also, we have to identify the rate, quality, use of accessory muscles during the respiration and periods of apnea and appearance of cyanosis. Then temperature, skin color, moisture and turgor. These are all affect due to deficient fluid volume. Then monitor intake and output chart and not urine specific gravity. Intake output chart we have to strictly monitor when the patient having deficient fluid volume. Risk for developing deficient fluid volume. Then maintain fluid intake at least 2500 ml per day within cardiac tolerance, because sometimes if we administer the more fluid, so it may causing the cardiac overload. Okay, then risk for impaired skin integrity related to decreased circulation and sensation caused by peripheral neuropathy and arterial obstruction. Patient having skin integrity impaired because of decreased circulation and decreased sensation. So we have to assess the integrity of the skin and check the deep tendon reflection and proprioception. એટલે in that if we assess the deep tendon reflection, then we have to reflexes, it will use foot cradle on the bed, use space moved from ulcerated heels, elbow protector and pressure relief mattresses. So we have to use the foot cradle on the bed so that patient does not develop any kind of foot ulcer. Then elbow protector also and pressure relief mattress, because this bony prominence get this bony prominence get infected, or it may develop sore in that particular site. Wash feet daily with soap and warm water. Check water temperature before immersing feet into the water, because patient may having poor sensation, so we have to check the temperature of the water. Then inspect feet daily for erythema or trauma, means any kind of erythema develop in the foot or not. Then so these are the other intervention in that. Change socks or stocking daily. Encourage the patient to wear white cotton sock. Why we are advising the patient to wear white cotton sock? Because if the patient may get any kind of injury, so easily it can be identified by if the patient wearing the white socks. Then use moisturizer on the skin. Then the patient should not walk barefoot. Uh, these are important thing that we have to advise the patient that do not go outside with barefoot. Always wear the shoes. Now the last one is risk for injury related to hyperglycemia, peripheral sensory neuropathy, autonomic neuropathy, immune system deficit, and vascular insufficiency. So these are all the causes that may causes the injury. So assess the general appearance of the foot. We have to first inspect the foot, status of the nail, skin integrity, and whether any callus formation or corns in the foot or not. Then evidence of infection and assess for edema. So these are the so for the prevention of injury, we have to assess all these things. Then instruct the patient to inspect the feet daily for cuts, scratches, and blister. Means any kind of cuts is there, scratches is there, or blister may develop in the patient. So we have to advise the patient that daily check for any kind of cuts, scratches, or blister. Teach the patient to inspect the shoes daily by feeling the inside of the shoe for irregularity or sharp objects. Sometimes in the shoes there is a sharp object that if the patient wear that shoe, so it may cause the injury to the foot. Then instruct the patient to always wear protective footwear. Instruct the patient to wear clean, well-fitting stocking made from soft cotton, synthetic blend, or wool. So these are the other things that we have to make sure for prevention of injury. Now, what are the priorities? Main priorities. We are moving on the end of this session. So nursing priority, so main thing in diabetes, that is restore fluid, electrolyte and acid base balance, correct reverse metabolic abnormality, identify 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 or assist with management of underlying cause, disease process, prevent complication. Yes, because there are lots of complication of diabetes, like diabetic ketoacidosis, hypertension, diabetic neuropathy, diabetic nephropathy. Then provide information about disease process, prognosis, self-care and treatment needs. Now, the intensive student of Sri G.H. Patel, means our institute, performed the research under the guidance of under the guidance of my a study to identify the nursing diagnosis among diabetic patients. So what kind of nursing diagnosis mainly seen in the diabetic patient and the association of demographic variable with the nursing diagnosis that we have to identify. So these are the frequency and percentage, means the highest diagnosis seen. We have collected 66 samples. In that 50 samples may have observed the 50 sample observe the impaired physical mobility, that is 75.8%, and the least diagnosis observed among 66 participants. In that three participants observe the imbalanced nutrition, that is in percentage 4.5%. Means among 66 samples, 50 samples, that is the majority of the diagnosis seen in the patient, that is impaired physical mobility. Now, the last one, that is the association of demographic data and nursing diagnosis. So, diabetic complication and visual acuity. So patient may develop, in the findings, complication and visual acuity is mainly seen in the association. Then there is a significant association between breathing pattern and weight of the patient. Means if the patient weight is high, the patient develop the ineffective breathing pattern. Then the third significant association also detected between the family history of the diabetes and ineffective breathing pattern. Means those who having the history of diabetes in the family having higher chance of developing ineffective breathing pattern. Then association develop between the age and GI complication. So there is a higher risk of developing GI complication in female than males. The last slide, there is a significance associated detecting between the age and physical mobility problems in the patient. Means those who having higher age, that is older individuals, seem higher risk of developing impaired physical mobility. Then insulin administer and physical mobility. There is an association between insulin administer and those who have taking the insulin may get chance of impaired physical mobility. And the last one is, it shows that incidence of disturbed sensory perception is higher in chance of there was significant association detected between complication related to diabetes. Means patients having sensory perception complication is higher. So this is all about the today's session, that is assessment, then nursing diagnosis, intervention, and uh, whatever the research study we conducted, that the result is shown in the last slide. So if any question is there, then you can ask.
I request to participants for ask questions. You can post your questions in chat box also. Is anyone have any question or query? Thank you very much, Ms. Nikita Chauhan, for enlightening and sharing your abundant knowledge with us. Thank you very much, madam.
Palliative care is a crucial part of integrated people-centered health services. Nothing is more people-centered than relieving the sufferings, be it physical, psychological, social, or spiritual. So, palliative care is an approach that improves the quality of life of patients.
So So here I would like to request Miss Anna Rao to provide us knowledge in a palliative care in diabetes. Yes, in the nursing field, and she is serving this institute course in palliative nursing from Pallium in the year of 2017. She is also associated with the palliative care training of our institute. We will now conclude this session. Now over to you, madam.
Thank you, Disha. What is palliative care? This is the definition given by WHO. The palliative care is nothing but an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So the definition itself says many of the things. All the important words are highlighted in red color, so that identifies that the patient uh, is the prime, or we can say center of our care. Naturally, right? We have learned always in nursing that patient should be at the center. But here in palliative care, it is not only the physical aspects. The main essence of palliative care is the quality of life of patient. Since 2 days, we are listening to many of the things which are giving troubles to our patients who are suffering with the diabetes. Now, not only the patient, but the family is also given equal importance in the care. Okay, and we have to take help of both the patient and their families, or you can say the close caregivers in the possible care. And it covers all the four dimensions of health definition that is given by WHO. That means the physical problems, psychological problems, social problems, and spiritual problems. So whenever we are even assessing the patient who is suffering with diabetes, take these four aspects into consideration. And plus, we have to give maximum possible care, and the patient should be free from pain. That is very, very important, and make him more comfortable. So that is the pillar of our palliative care. If you have any of the myths or any misbeliefs in your mind about the palliative care, kindly remove that. Namely, that palliative care is the end of life for the incurably ill. It is not that. And second myth, many times it goes with palliative care, is that it is aimed specifically at cancer and AIDS. These two, of course, come into our mind first, because most of the patients who have cancer and AIDS, they suffer a lot, and we try to do maximum comfort. So many times palliative care gets associated with these two conditions only, but it is not so. There are plenty of other conditions also where the patients are, that we will see. Here we can see that there are chronic conditions, or which are progressively becoming problematic to the patient. It may lead to untimely big issue. There are many other conditions like obesity, paralysis, and respiratory conditions also like COPD, heart disease, and fever, dementia people. So there are lots of cases of palliative care. Diabetes is palliative care is only the thing that have to give maximum comfort to the suffering. So exploration need to be done that what should be done to help the patient. Commitment should not be abandoned. Patients should not be abandoned whenever the cure is not possible. That's so in figure also you can see nicely expressed that treat the whole person, promote quality of life, support the family, should not support, forget the family. Okay, and it is an extra layer of support for all the people who are concerned with the patient and look beyond physical issues. That is very, very important. Let us move to the focus on palliative care in diabetes. Now, there are two things here. First is that patient is suffering with diabetes as primary condition, whereas many of patients who are suffering with other conditions, but simultaneously they have diabetes as secondary condition. So both of the things are included, and many times we have so much of problems to deal with when we do. So, managing diabetes is always a challenge because it is very chronic and day by day there are more and more problems we face in his or her life. But with adequate care, we can negotiate with a healthy living life. So that should be remembered. Prime focus should be on safety, comfort, and quality of life rather than achieving tight blood glucose control. Many times we focus only on thing, that is maintain your blood glucose. Yes, that has to be done, but there are other things also which need adequate concern. Doing appropriate assessments and monitoring is must. This will help to promote comfort and quality of life by these things that guiding in decision making and avoid unnecessary burden of care on patient also and the carers also. Okay? And manage all the unpleasant symptoms. These things are always kept in mind. Regular blood glucose monitoring, of course, helps to identify hypo or hyperglycemia. But many times in end stage, it gives unnecessary trouble to the sufferer, that is patient. So we always have to remember that end of life should not be trouble to the patient. Nurses, what we should do further, develop the care plan and never forget that include the caregivers, that is close family members. So whatever care plan you develop, always include patient as well as the caregiver. So it should be personalized to suit individual's health and functional status. Medicine regimen should always be taken care of. This profile, as Nikita ma'am just explained, all the nursing care very much in detail and very nicely. And we are all of us are sure that with these points, you will be able to take care of your patients very effectively. Always look for the life expectancy of the patient. Of course, the life and death are not in our hands, but we do come to know, patient also come to know that end is near. So at that time, these things become very important. And uh, lastly, but not the least, that it should be developed with the individual and family carers, as I told you so many times. Keep in mind that patients with is always want to be comfortable. Many times they have many cravings. Yesterday, Dr. Jyoti Madam also described how to get rid of his cravings. Okay, so we should take into account and remember the points how to develop diet menu and all. Also want to avoid high and low blood glucose levels because they cause discomfort like headaches and many others, plus feeling dizzy and tired and all that. Sometimes it is very hard to know what person feels. Uh, I mean to say that whether the conditions are because of the patient's diabetes or other comorbid conditions. Okay, so that need to be identified what is the exact problem. That is where the assessment is coming into picture, and it is very important. Fine. So once again, we are reminding you what are the small signs and symptoms, list of signs and symptoms in hypoglycemia and hyperglycemia. Okay, so we will go through quickly. Hypoglycemia means feeling of weakness, confusion, irritability, hungry, tired, or shakiness. They may sweat a lot or get headache. If their blood glucose drops very low, they could pass out also, have seizure also. Okay, so for diabetic patient particularly, many literature says that it should not fall below 6 millimole of per liter. Okay? And high per glycemia, you will the patient will feel this, feeling thirsty, tired, have blurry vision, have to pass urine very often. That will make him very uncomfortable, especially if the patient is bedridden. Then it is quite a lot problematic. Very high blood glucose may also make them feel nauseous or even, or they may vomit also. These things can occur. So diabetics again, the height limit is 11 millimole per liter. Generally, patients, diabetic patients' limit for blood glucose is little higher than the normal people. Carers should know how the patient takes care of himself. When patient is not able to take care of himself, uh, then of course the near and dear one will be responsible to give care. So when we are living with the diabetic patient and the patient is very sick to do self-care, we should always learn how the patient is taking care of himself or herself. So, how they are checking their blood glucose, how they are comfortable, what medicines they are taking, how they inject insulin, what is their preference of site in injecting insulin, and you can see even them administering insulin themselves. Okay, so when they are taking insulin, we have to observe them. That what are their preference of site, how they are taking. Okay, because when we are taking insulin ourselves, we have to poke ourselves so that we are very conscious. Okay, when we are checking RBS for others or taking IV lines for others, we uh, I don't know how many of us actually feel that pain. Okay, but when we have to undergo that procedure ourselves, then we are taking very careful. So we have to observe them, ask them how they feel about writing down the problems, and uh, in particular advanced management, advanced care planning. When they are very sick, what they would like to do, make list of them. Okay, all the points should be written down by the carers and take into consideration. So this advanced care planning is very, very important. That will help carers a lot when taking care of the patients in their end of life care. So check out preventing and managing diabetes related complications. It is very essential. And most of the times carers, they do want to take the RBS into consideration. Many times patients do encounter many stable and unstable periods before they begin to deteriorate towards their terminal stage. So careful observation of the patients is very essential. When carers are having any problems, they can always contact the uh, healthcare personnel. That should be important. They always should be having emergency numbers so that it is possible. Any intercurrent illness or any problems that arises during their life will alter their uh, glycemic index, or you can say glucose levels. So those points also need to be considered. Many of the patients have antihypertensive diet, drugs, lipid-lowering medicines, anticoagulants also for other comorbidities. Most of the patients are, you can say, they are on plenty of medicines. So all interconnected, any problems are there, complications, side effects, whether they are affecting diabetes or not, that should be seen. At the end of life, we also need to see that how much beneficial these medicines are. Okay, all unnecessary medicines should be removed to avoid or to reduce polypharmacy. Pain management is very, very essential in uh, palliative care. We all know that it is the fifth vital sign. Okay, and following of WHO letter is must after thorough assessment. So many times the patients also use alternative therapies, herbal medicines. So whether these medicines are making any impact on their glucose level, check if they are taking corticosteroids or not. Because that will also affect glucose level a lot. Consider various other methods like use of essential oil, massaging, music therapy, guided imagery, acupuncture, pet therapy. Okay, there are essential oils also, vaporizers also. Okay, that also help. Meditation, of course, is the best. So it is very essential to keep the patient free from pain. Nutrition and hydration, as we have already seen this point. So many times it happens that we give many instructions to patient: eat this, don't eat that, okay, and the patient will end up in taking less diet, having which is lacking essential nutrients. So patient becomes deficient and anemic. So these things should be taken care of. And many times it is more important whenever the patient is having renal disease or patient is having, many times it happens that well is included and patient are having now problems. So supplementary nutrients, including protein, should be taken care of in the planning of that diet. If the patient is not able to take food orally, so many times enteral feeds may be required, but always remember the risk and benefits in giving these things, including the risk of accelerating death or individuals' conditions should also be where we are opting for enteral feeds. Risk associated with enteral feeding will also include nausea, bloating, diarrhea, okay, and all this will land up in patient being uncomfortable and the quality of life will deteriorate. So, actively dying person may feel no take it. Person may feel thirsty, but the thirst will not be quenched by artificial hydration. So, adequate mouth care in that condition. When to withdraw treatment? Of course, it is a big ethical issue also associated with such procedure. But when the patient is at the end of life, we will always see into many of the things. and clear documentation of all the problems and the solution, whatever vendor is very important. So discuss such issues with the patient and family members and inform them that they have right to stop the treatment if it is no longer beneficial and it becomes burdensome. We all want that patient should be at a comfortable level, and patient also would love that and die with dignity. So factors which suggest that individual has short prognosis will include like presence of multiple comorbidities, weight loss more than 10% in short period of time, failure to thrive or general decline is there, performance is declined very much, significant help is required by the patient to do even smallest job, and of course supporting carers is also very essential. The involvement and developing care plan, regular review with the help of loved ones very much uncomfortable. Please take care of. Caring is also associated with increased risk of myocardial infarction. Here the patient is sufferer, but along with them, their carers are also equally suffering. And it is many research papers are published in this regard that the carers are also having quite a lot of psychological. Whenever as nurses we are giving care, always inform carers and find out their problems. That is must. There is no situation where nothing can be done. And we need care, but no need to care. That these golden words should always be remembered. So, in regular care, what the patient's relatives care of bed, and of course, that the position should be changed, bed soap should be prevented, so the positions, what are the most possible sites where the patient can develop. Care of wounds, that is very, very important for the diabetic patient. So, observation of food is very essential. When the patient is not able to take care, hygienic care, mouth care, all types of care. Care of comorbid issues. As we have seen, many patients have other comorbid issues also should be plenty of medicines. It is seen that old age people mainly have around medicines they have to cut. So polypharmacy is the biggest problem nowadays. We help patient, but at the same time, patient will end up into problem also. If the patient is in catheter, then the catheter care is very, very essential. Diabetic patient with catheter is a lot more problematic. We have to see that the patient doesn't get infected. Uh, Short-term catheterization, long-time catheterization, everything should be there. Feeding and nutrition in last stages is important, whether to eat or not. Hands-on training to caregivers from time to time. It is very essential. Never to forget that palliative nurse, she affirms life and promotes quality of life and provides treatment. In short, this is our take-home message. Thank you, everyone. Take have any query, you can please put in the chat box. So you can have discuss.
Now, I request to participant for ask the question or any query. Also, you can post your question in a chat box. If anyone have a question, please ask.
Okay. Thank you, Anna ma'am, for your valuable talk. It is glorious moment to extend our warm wishes on behalf of Sri G.H. Patel College of Nursing. I would like to convey a heartful gratitude towards Dr. Jyoti Manari ma'am and Dr. Poonam Bhinde ma'am for accepting the invitation and presiding over this webinar on World Diabetes Day 2020. I request you, ma'am, Dr. Jyoti Manari ma'am and Dr. Poonam Bhinde ma'am to continue this session. So I request both ma'am to take over this session.
Thank you. Can you see the slides? Is the slide visible?
No, ma'am. Slide is not visible.
पीपीटी तो खुला है कहाँ यहाँ कुछ दिख नहीं रहा है नहीं ये not this ये तो खुला है but the question is हाँ go back to the share screen once Are we they made us a host, by the way? Have you made us the host? Anna madam?
Yes, madam. We made you co-host.
Okay. I am unable to share the screen.
And we are unable to start the video also. Can you change the setting to anybody can start the video?
Yes, ma'am.
हाँ.
Is it now visible? The slides are visible? Is the slide visible?
Are we seeing?
Can you see share screen?
Can you
Yes, ma'am. Voice is audible.
voice is audible, video is not seen.
Video is not seen.
I,
Can you allow us to share the video? I mean, the setting has to be our video should be.
Setting is done, ma'am. Already setting is done.
वहाँ पे आया था ना, फिर से हम नहीं दिख रहा है कुछ। हम्म।
Madam, can you down the strip? No, there is a button share screen, green color.
No, I'm not.
Is it coming?
Yeah, we are just
All the participants are requested to please be remain in the meeting. There is some technical problem, so we are solving it.
now we will start. Now we allow. Now it will be visible.
Visible now? Are the slides visible?
It's coming, ma'am.
Is the slide visible?
No slide is not there,
Okay.
but you can see.
So, yes. Slide is not visible?
No, ma'am.
Ma'am, okay, choose one and then you say you can't choose.
Ma'am, below side share screen option is there of green color.
Hello, madam, can you see the share screen option on the screen? No. Dear participants, dear participants, because of some technical problem, we are unable to go further, but we are doing our best. It will take some time. Finally, stay tuned. Thank you.
Is it visible?
No, ma'am.
Can you please your PPT on the screen?
હવે સંભળાશે.
Nurses do play a vital role in prevention of diabetes and early diagnosis of diabetes and also complication related to diabetes. They are partner in healthcare, and this year being 2020 being the international year for nurses, and I firmly believe nurses do play a vital role in prevention of diabetes and in change of lifestyle modification. As I mentioned, our partner in healthcare. There are nurse practitioners which are being recognized by Indian Nursing Council. They are trained to handle diabetic patient. Of course, low cost comes because you don't need to go through a consultant referral. They can, and diabetes is a common disease, and nurses can very well handle that. They can train the person as soon as a patient enter a hospital. They can play a very vital role in community upskilling and training the people in the villages or in a primary center. They did have a basic training during their training program, but they do need a upskilling because now, as I mentioned, there's a nurse practitioner who can handle only diabetes. So they require a upskilling, and then moreover, there are trends changing. The requirements are changing as diabetes being a very common disease in India. They need to know what best online process can be done. Now we have monitoring which can give a real time timely value of the sugar, what changes need to be made. So they do need upskilling. I, on behalf of all the nurses fraternity, being a senior nursing member, I will make all the nurses and myself pledge that this year we should upskill our nurses to handle patients in a better way and to prevent any complication happening from diabetes.
can see the slide.
Can you see the slide?
Yes, ma'am.
Okay, fine. So we'll start. For these technical delays. Start with foot care in diabetes. What we need. Are you all able to hear?
There is some problem in voice, no? My voice is not coming.
हाँ मैम whichever is working. वहाँ पे हो गया but then I how long it will sustain.
Excuse me, ma'am. Voice is not coming.
But same story.
So I think you make me the co-host now, so that I'll see my slide share.
Okay.
Is the slide visible?
Yes, madam.
Is the slide visible?
Yes, madam.
Okay, so I'll begin after a lot of hassles. I hope it goes smoothly. Now, why is foot care so important? The issues are once an ulcer develops, if the patient has a insensate foot and he develops an ulcer, there is an infection in the ulcer, there is repeated trauma, morbidity increases, cost of treatment, hospitalization, repeated visits for wound dressing, non-healing ulcer then gives rise to further morbidity, sepsis, ICU stay, surgical management, amputation, depression following amputation, further cost of prosthesis, etc. So to avoid all this, we must aim to save the limb of the patient and save the life. Therefore, foot care becomes the most important. So how does a patient of diabetes develop diabetic foot or develop ulcers on the feet? The reasons are twofold. One is neuropathy on one hand, second is the vasculopathy. We all have learnt yesterday also that complications of diabetes result in neuropathy. Neuropathy leads to sensory loss, motor involvement, and autonomic neuropathy. When there is sensory loss, there is loss of pain sensation. Painless trauma gives rise to trauma to the limb, to the feet, giving rise to a foot ulcer. If there is motor involvement, there is small muscle weakness, foot deformity occurs, extra pressure point occurs, and that further leads to development of ulcer. And autonomic neuropathy gives rise to dry skin. Dry skin gives rise to itching. Itching gives rise to an ulcer. So this is the reason why neuropathy gives rise to a foot ulcer and the foot ulcer further leads to infection, further leads to deformity. Deformity can lead to further ulceration, further infection, and then leading to amputation. On the other hand, you have vasculopathy, which can be microvascular and macrovascular. Microvascular gives rise to skin ischemia, skin devitalization. Large vessel thrombosis in macrovascular can give rise to skin gangrene. Gangrene can give rise to an ulcer and infection. So all in all, diabetes giving rise to foot problems when can further give rise to further problems. So it's a vicious cycle. So how do you know? How do you come to detect the feet at risk? There is something in the history and lots of things in examination which will get you to identify the high risk feet, right? High risk patient nathia, it is high risk feet. So the feet at risk can further be prevented to develop an ulcer. So what in the history, if there is a prior history of amputation or prior history of foot ulceration, you have to be careful. If there is a history of coronary artery disease, they tend to have peripheral arterial disease also. So these are few things which in the history will point towards development of diabetic foot. On examination, if there are loss of sensations, if there is a foot deformity, if there is absence of pulsations, you look for peripheral arterial disease in the form of pulse of posterior tibial and dorsalis pedis should be looked for. You also look for reduced ankle brachial index. That means blood pressure in the upper limb and blood pressure in the lower limb. Both have to be taken, which means you tie the cuff either at the level of the calf. The blood pressure cuff is tied at the calf and you take the systolic blood pressure by palpating the posterior tibial artery. So with that you come to know that the blood pressure, systolic blood pressure in the lower limb is say 130 and systolic blood pressure in the upper limb is say 110, then it is normal. So the ratio of ankle blood pressure to the upper limb blood pressure should be more than or equal to 1. If it is less, that means the lower limb blood pressure, circulation is not good, right? So physical examination of the feet in persons with diabetes, you look for neuropathy with the help of, one is your tuning fork that you have in the wards, 128 megahertz tuning fork, and second is the monofilament, which is this is what a monofilament is. The wire which is there, This is the wire, and that is the wire which is knuckled, and the patient is asked for feeling of the sensations. These sensations are felt at 4 or 5 sites. These are the 4 sites, right? Great toe, the first metatarsal head, the middle toe, and the last toe. So these are the 4 sites where you test with the help of the monofilament to see whether they have the sensations or not. Heel is not tested because the heel is the least sensitive area. So you test on these areas to know whether the patient gets the feeling or the sensations. Before testing on these areas, you should show them what the test is by applying it over the hand or forearm to show that this is the sensation that you should get. So bow into the C shape for 1 second, test over 4 sides. Heel testing does not predict ulcer because it's a very thick skin over the heel. So these are the ways in which you know whether the patient is having sensations or not. So insensate at one site is an insensate foot. Falsely insensate with edema and cold feet. Test annually when sensation is normal. Use the monofilament less than 100 times a day. Replace if it gets bent. Replace every 3 months. So monofilament is not used because it is not frequently, I mean, you'll have to waste a lot of monofilaments. Therefore, you can also use the tuning fork to look for vibrations. That will also give you an idea of whether the patient is having any neuropathy or not, right? There are other instruments also to do it. The other is the motor neuropathy. Motor neuropathy, you look with the help of hammer toes, claw toes, prominent metatarsal heads. I'll show you some photographs. This is what is a hammer toe, right? Because the patient doesn't get the feel of the ground, therefore he starts walking with more pressure applied, and therefore the foot develops a deformity which is called as a hammer toe. Then this is a claw toe, right? Now what happens is once the patient starts walking like this, then the pressure over this area is increased, and therefore that becomes a skin of that area develops a subcutaneous hemorrhage. Then there is a breakdown of the skin, and then the infection starts with the bone involvement giving rise to osteomyelitis. So these are the problems. This is a hallux valgus. So here this is the pressure point, and there if the patient is wearing shoes, this will pressure point will further lead to infection, right? So these are the various deformities, and if the patient develops clawing, then these are the pressure points, and therefore if he wears a shoe, then these are the areas where it will go on pricking or pressurizing and develop ulcers. When the patient develops a hallux valgus, then there will be crowding of the feet and there will be infection in between the toes. Okay, these are the various sites where there will be pressure points. When the patient has a deformity like this, pes cavus, then these are the pressure points. And once he develops a charcot foot, then this is the pressure point. So these are the various areas in which ulcers can develop. You can see this is one photograph showing pressure giving rise to redness over here. This is a hallux valgus. These are the pressure points when the patient develops clawing. Here you can see the pressure points. If there is a loss of slides, please let me know, because I am going ahead thinking that everything is visualized. Please unmute your mic and talk if there is any problem.
Ma'am, it is visible.
Okay. So here you can see callus is developed because the patient doesn't have sensations, right? So pressure developing, giving rise to skin thickening, and this is called a callus. You can see how badly the skin is managed or the foot is managed, because they don't look at the feet, they do not see that there are loss of sensations, and that results in further problems. This is a charcot foot. You can see that this is the arch which is normal. When the patient develops diabetes and autonomic neuropathy, then the arch breaks down, giving rise to a charcot foot, and that is then giving rise to an ulcer over the pressure point. You can see the loss of the plantar arch, giving rise to the complications. Vasculopathy, peripheral arterial disease, is one of the common macrovascular complication in diabetes. Coronary artery disease and peripheral arterial disease go hand in hand. Therefore, those patients who have peripheral arterial disease, you should look for CAD and the vice versa. So if your patient has CAD, you should look for peripheral arterial disease. Once you look at this, so how I just now talked about ankle brachial index, this is what it is talking about. Patient may have claudication. You know what claudication is? When the patient walks a particular distance, there is lack of blood supply to the limb because of the macrovascular involvement. Therefore, the patient has pain in the calf when walking. After a fixed distance, the patient develops a pain in the calf. He has to sit down. After he sits for some time, again he is able to walk. This is what is called as claudication, intermittent claudication. So if the patient develops intermittent claudication, he should be able to tell you, and or you ask details and you come to know that he has peripheral arterial disease, which is one of the symptom of peripheral arterial disease. So how do you know? Absent pedal pulses predict severe peripheral arterial disease. Absence of one-sided peripheral arterial disease, single pedal pulse does not predict peripheral arterial disease. It is bilateral, it cannot be unilateral, right? So you have to look for peripheral arterial pulsations on both the limbs. One side absent does not talk about PAD. Presence of pedal pulses does not rule out PAD also. So therefore, you need to check the ankle brachial index, which I talked about. These are other methods of doing it. This is a Doppler, handheld Doppler, and this is called TCPO2. These are available in our hospital. This is available. Doppler is available. This TCPO2 is not available. So you can take the help of the Doppler and you can check it, but you can do it with the hand also. If the peripheral pulsations are not palpable, then you need the Doppler to go in for detailed evaluation. Right? This is the way it is taken, and then you take the index. So normal is this 0.9 to 1.3, mild obstruction 0.7 to 0.89, moderate 0.4 to 0.6, severe obstruction is less than 0.4. Okay, so you must try and do this as much as possible. So how do you stratify the diabetic foot? I mean the foot showing a high risk. So this is the way. If you find peripheral arterial disease or neuropathy, then you try to categorize the foot, whether it is normal, whether it has any one or combination of the following or any of the following. So this is a normal foot, no skin abnormality, no structural deformity, no vascular problems, and protective sensations are intact. This is a normal foot. So if it is a normal foot, then you examine once a year. This is a low risk foot. Any one of the combination, skin abnormality, that is you have some loss of skin barrier is lost, structural deformity in the form of hammer toes, claw toes, etc., limited mobility, loss of protective sensation, and vascular problems. Any of this means it is a moderate risk foot. And skin breakdown, that means an ulcer has already occurred, past or present, or amputation has occurred. This is a high risk foot. What is the importance of knowing this? After knowing this, you are supposed to give accordingly you give them the advice. So annual comprehensive foot examination, inspection of feet, every office visit, podiatric care, intensive patient education, detect or manage barriers to foot care, and therapeutic footwear. These are the things. I'll talk about details of this. So if you have a high risk foot, then you should label that to the and convey to the patient also. Every visit, you should ask the patient to remove the shoes and socks and examine the feet. You can reach out, see the there is a possibility that the patient is unable to see the feet because he is obese, because he is not able to bend down to see the feet. So it becomes important for us to look for the feet of the patient, soles of the feet, examine properly, and then give them educational advice. Nail and skin care. Nail care is important in the sense that you should tell the patient to cut the nails in such a way that the ends are not cut. While cutting the ends, usually they damage the skin and they result in infection further. Also, result footwear should be also advised. So what do you mean by footwear? I'll talk about it later. So every time the patient comes to you, you must reinforce and talk about the same thing, talking about foot care. Patient demonstrates self-care knowledge and then you look about it. Now you can see bad footwear. Why do you call these bad footwear? If the patient wears a high heel, the pressure over the toes increases, right? So therefore development of ulcer is common. So these are bad uh, footwear. Okay, if they wear pointed shoes like this, again development of deformities of this sort will occur. So narrow toe box gives pressure to develop a hallus valgus. High heel shoes give pressure on the metatarsal heads. Both of these are bad, right? What this can give rise to further injuries to the patient. Stilettos, I talked about it. Slippers, what is the problem with slippers? They will come out, they will not come to know. Patient does not have sensations in the feet. So if he wears slippers or chappals, the chappals will get out of the feet and the patient will not realize, right? So all this has a narrow toe box. So all of these are bad footwear. So what is a good footwear for a diabetic? The toe box should be wide. This is called the toe box, where the patient puts the toes. That should be wide enough. The insole, the portion which is inside is called insole and this is called the outsole. The insole should be soft. The patient should fasten the the shoes with the help of either Velcro or thread. Okay, smooth lining, low heel, thick flexible shoe soles. Toe box should be sufficiently long, broad and deep with a deep clear space between the apices of the toe and the toe box. Shoes should be fastened with adjustable lace, strap or velcro. The heel of the shoe should be less than 5 centimeters to avoid weight being thrown forward onto the metatarsal head. Stocking or socks should always be worn to avoid blisters. This is a bad shoe, right? The outsole is very soft, flexible. Therefore, more pressure will fall on the toes. Okay. So these are few things which you must know while you are advising. So do's in foot care, you should always empty the before the patient, because patient doesn't have sensation. So if he puts the foot into and wears the shoe, there'll be a small pebble inside which will go on pricking and develop an ulcer. You can see about how to cut the nails. Always give a mirror to the patient so that if he is unable to see the sole himself, then he should use the mirror to see the sole. What is wrong in foot care? Never allow the patient to use the blade and remove the ulcer or callus, right? This is what has happened to a person who has put his foot on the silencer, now doesn't have sensation, therefore heat gives rise to a blister formation. Here he is walking barefoot and develops problems. So all the 3 points have to be remembered. Patient does not have sensation, therefore he should always wear shoes or sandals. Shoes or sandals. Mojadi pan chale, shoes pan chale, sandals pan chale. Because the footwear will come out and patient will not realize, right? He should not walk barefoot is one important thing which has to be remembered. Okay, these are few devices which are used to for ulcer healing. These are the Jaipur foot that is available. Okay, so therefore, to summarize, always diabetics should be examined to see whether there is neuropathy or not. Whether they have neuropathy or not, you should try and identify the high-risk feet with the help of the tuning fork. Always educate the patient or the relatives for care of the feet. educate about footwear. So therefore, it is important as healthcare workers that we take care of the foot to see that diabetic foot ulcer do not result in amputation. Thank you so much. I'll hand over to Poonam Madam for insulin. If there are any questions, we'll take it at the end. Thank you.
Thank you, madam, for your valuable talk.
Thank you, ma'am. So now we take up insulins. We learned yesterday that the treatment which is available can be divided, the pharmacotherapeutic treatment can be divided into oral medications and injectables. We learned about the oral yesterday. So today we'll talk about insulins. So as we know, insulin looks something like this. Native insulin looks something like this. And we talked about C-peptide, and you can see that a part of insulin, when insulin is secreted, C-peptide is a part of that which will detach away. So by measuring C-peptide, we get a fair idea of how much insulin is being produced. Insulin, because of the fact that there are so many companies manufacturing insulin under so many different names. That is why rule number 1 is do not get confused or do not get carried away by the trade name or the brand name of the insulin. Always look which type of insulin is there inside. So if you go by the brand name, there is going to be confusion because there are so many companies. So always remember to look the content rather than the trade name. So insulin is a molecule which has been around for so many years, right from 1922. Initially, there was bovine and porcine insulin which is being used, but the insulin which we get now is manufactured by recombinant DNA technique. So remember that there are older insulins and there are the newer insulins. Newer insulins are called as insulin analogs, and they have better time profile, means they either start acting within 10 to 15 minutes after giving them. These are the short ones or the rapid acting ones I'm talking about, and the long acting ones act for almost 24 to 36 hours. And the older insulins are what we are all familiar with. We have the regular insulin and the NPH insulin. Okay, so the older insulins are regular, NPH, and a mix of these both. We know names called Actrapid, we know names like Insulatard, and we are very familiar with names like Mixtard. What are these? These are nothing but older insulins. Actrapid is regular insulin, NPH is sold by the trade name of Insulatard, and Mixtard is these two mixed together. The company mixes it in different proportion and packs it. So that is available to us as Mixtard. If it is 30% of insulin which is regular and 70% is long acting, we call it Mixtard 30. And if it has 50% short acting and 50% long acting, we call it Mixtard 50. Very simple. These are the older insulins. Newer ones are, the rapid acting ones are Lispro, Espart. We know names like Epidra, which is Espart. We know names like we know names like Novorapid, which is S-part, and we know names like Epidra, which is Glulysin. We also know Glargine, which is Lantus, and Levemir, which is Detamir. So don't get confused by the brand name. See what is there inside it. Now we know that the shorter acting insulin, the regular one which we use, Actrapid, as we all are familiar with, is a brand name. It can be identified because there will be a yellow band on the vial as well as the box. So yellow means regular insulin. We give it half an hour before food because it takes time to start acting. The peak action is at 2 to 3 hours and the duration of action is 6 to 8 hours. It is just like water. It's a very clear solution. Can be given IV, that is intravenous, and subcut as well. And you can mix this with NPH. Okay, and these are the common brands available: Actrapid, Insugen R, so Insulin R. So R is regular and it has a yellow band. These are all the different types that is available. Those are available. You have them coming in vials. You have them coming in pens which are disposable pens, or you have pencils which you can put in a permanent pen. Also remember to see the strength of insulin, whether it is 40 IU per ml or 100 IU per ml. Because if it is 40 IU, then you'll have to use the red syringe. And if it is 100 IU, you'll have to use the orange syringe. Moving on to NPH, it is a longer acting insulin identified by the green band. We said regular is yellow and NPH is green band. This is to be given only subcutaneously, cannot be given IV. The onset of action is 2 to 4 hours after injection. Peak is 4 to 10 hours and the duration is 12 to 18 hours. It's a cloudy or a milky solution. We are familiar with these brands. Look at the green band here, available in vials, dispo pens, as well as permanent pens. Now, if these two are mixed and handed over to us, the company will mix it and give it to us. And they are called pre-mixed insulins. And the brand that we are familiar with is a Mixtard or Insugen 3070 or a Hume Insulin 3070. This is identified by the brown band. Which one? 3070. And 5050 is identified by the blue band. The numbers are nothing but the amount of regular and NPH insulin. So if it has 30% regular and 70% NPH, it is called 3070. And if it has 50% of regular and 50% of NPH, it is called 5050. Again available in vials, dispo pens and pen fills to be used in permanent pens. Once we are thorough with this, then we can have a quick look at the newer insulins. These are the latest, not latest, they have been around for so many years, but nothing has come after that. So we still call them new insulins. They're no longer new because they've been around for a pretty long time. However, these are like designer insulin. They have better time profile. That means when you give an injection of Aspart or glulicin or Lispro, you did not wait for 30 minutes as you would for a regular insulin, because these act within 10 to 15 minutes. So they can be given 10 to 15 minutes before food, with food, or even after food. Similarly, if you are going for a long acting like a Lantus, it has to be taken once in 24 hours, unlike a NPH which has to be given once or twice a day. So what are the vials? You have Epidra coming as, you have glulicin coming as Epidra, you have Aspart as Novorapid, and you have Lispro as Humalog. They again are available as dispo pens and also as pen fills. This is Lantus and this is Tresiba, which is Degludec. This is a very long acting insulin, can act up to 36 hours. Now you also need to know that different companies which produce different insulin have permanent pens as well, and the permanent pens are given different names. So you have all-star pen which is manufactured by the Sanofi company, which can be used with pen fills of Lantus or Epidra, because the same company which manufactures the insulin, you have to ideally use a permanent pen of the same company. If you are using Novo Rapid, then you would go for Novo Pen. And if you are using Insugen, which is the product of Biocon, then you would go for Insupen. Okay, so don't get confused. The names of pens are only the names of pens. They have no relation to the insulin. The pens are very specific for a particular company, and you are supposed to use pen fills of that same company for those pens. So do not think that Insupen is to be used with a particular insulin. You can use any pen fill of Biocon company in a Insupen. You can use any pen fill of Sanofi company in a All-Star pen. And you can use any pen fill of Novo Nordisk company with a Novo pen. Very simple. Now, after knowing what the insulins around us are and what they look like, we have to know how to store insulin. So we all know that if it's not in use, it has to be kept in the refrigerator in the door section, where usually we keep butter and cheese. If a pen is in use, then ideally we should not be keeping it in the fridge unless the ambient temperatures exceed 30 degrees Celsius. So all insulins remain stable and effective if kept between a temperature of 15 to 25 degrees Celsius, max up to 30. Beyond that, like in summers, ideally we should be keeping them in fridge because the temperatures easily exceed 30. Once opened, we should preferably finish it within 28 days. Now, we do see a lot of patients who do not have access to a refrigerator, or they are in very remote places where there is no electricity. So, how do you tell them to store insulin? You can read about how to prepare a Zeer pot online. A lot of videos also are available, but it's a one-time investment. If they spend a little time and energy to create or prepare a Zeer pot, storing of insulin can be easily done in a Zeer pot. You can get the links online how to prepare one. But luckily now we don't meet people who do not have a fridge, so that's okay. But just remember about Zeer pot. You all are familiar with the sites. You all know that insulin has to go in the subcute tissue. So obviously the sites are marked where the subcute tissue is enough. So what are those sites? Abdominal wall, arms, upper and lateral portion of the arms, the thighs and the gluteal region. Now one would ask, is there a difference in the site? As far as the subcute tissue is concerned, it depends on how fat or thin the person is. But yes, as far as the speed of absorption of insulin is concerned, there are reports that yes, it differs. Means if you give it in the abdominal wall, it will have a fastest absorption. Second comes the arm, third comes the thigh, and fourth comes the gluteal region. Now, many times patients take insulin 2 times a day or 3 times a day, sometimes 4 times a day, and they end up injecting it the same place. Now, that is not correct. So, we should advise them to keep changing the sides or to keep changing position in one side. And there are many methods to do it. I have shown 4 patterns: horizontal pattern, curve pattern, zigzag pattern, crisscross pattern, whichever the patient prefers. Also, you have now these paper cutouts with days of the week written. They are available online and you just have to take a printout and cut out the areas marked in a dotted line. So, a patient who's forgetful, who doesn't remember where he had taken insulin in the morning on a Monday, can take help of such cutouts. They just have to place it on the site of injection. Remember what the day of the week is, remember what the time of the day is, and inject the insulin in that spot or a slot. Now, why do you want a person to change side? Because if you keep on injecting at one side, then the patient may end up with something called lipodystrophy. Lipodystrophy can be lipohypertrophy, wherein the fat cells are increased, or lipoatrophy, where the subcute fat disappears. Either way, whether you have a hypertrophy or a lipoatrophy, be sure that it is going to interfere with the insulin absorption, and very difficult to manage such patients. Also, when a patient comes to you who's on insulin for a long time, please touch the site of injection. See if the patient is already having lipodystrophy. So if you find a lumpy, if you get a lumpy feel at the site, that means the patient has lipohypertrophy. Or if you feel depression when you touch, then it means the patient has lipoatrophy. And the patient should be advised to stop injecting insulin at that particular site. This is how the lipodystrophy will look. You can see on the thighs, you can see those big lumps. They are nothing but the fat. Similarly, on the abdominal wall, you can see this is lipoatrophy or lipohypertrophy. Okay, the last section deals about the self-monitoring of blood glucose. As the name, the term itself explains, it is nothing but it is where the patient monitors his or her blood sugar using a glucometer at home and maintains the records, which helps us to adjust the dose of insulin or tablets. Now, patients who are on tablet by and large did not monitor their sugars every day. But people who take insulin ideally should. Somebody who's on tablet and doing fair, you need not tell them to check every day. There are different organizations have different guidelines. Now, this is from the International Diabetes Federation. It states it's often unnecessary for patients to perform daily self-monitoring, but just to keep them, in the know and involve them more in the diabetes care, you can give them something called 5 or 7 point or staggered profiles. How do they look? Can you see this week timetable and the crosses marked there? So if you are asking somebody to check before breakfast, after breakfast, post lunch, post dinner, and a pre-dinner, that means 5 times a day, that is called a 5 point profile. And if besides this you are asking for pre-lunch and a bedtime as well, it means a 7 point profile. You also have something called a staggered profile. Means you can check fasting and a PP on a Monday. You can check before and after lunch on a Tuesday, and a pre-dinner and a post-dinner on another day. Or you can go once on few days. Like if you check fasting on this Monday, then maybe after breakfast, after 2-3 days, after lunch, after 3-4 days. So patient knows what his sugars are like. What about people who take insulin? If a person is taking insulin, then it's better that they check their sugar at least once a day. And if they are taking multiple insulin, then they have to check at least once a day. But unfortunately, it's not possible in our setup. So we end up giving a staggered profile to most of the patient, wherein they have to go to a nearby lab once in few days and get their sugars tested with the glucometer. But you should know that SMBG is a very powerful tool, and it is proven beyond doubt that when the patients check their sugars at home, get involved in the diabetes management themselves, compliance is better, dose adjustments become more frequently, and glycemic targets, like we discussed the magic number 7 yesterday, are achieved much earlier. So there are days or times where you may have to do a frequent check. If somebody is sick, somebody is pregnant, somebody is in the hospital, or the sugars are fluctuating, or patients are on steroids, or you are making changes in the treatment plans, or patients are experiencing hypoglycemia, then you will want them to check very frequently. And they have to maintain a log which looks something like this. Now, glucometers have been around for a long time, wherein you need a machine, you need the battery to be in place, you need those lenses, you need those strips which are not available all the time. Now, with advancement in technology, you have newer devices for monitoring as well as insulin delivery. So a person does not have to keep on injecting multiple times a day. You have something called a flash glucose monitoring device and a continuous glucose monitoring device. Flash glucose monitoring device comes with a sensor and a reader. The thing attached to the patient's arm is called a sensor, and the thing in the right hand is a reader. You always have apps now. You don't need a reader as well. You have apps which you can download on your mobile. You can connect the sensor to your arm. You can activate the sensor using that app, and you can read all the readings that the sensor captures on your mobile. It is so simple. However, the limitations are it can capture data only for a period of 14 days, after which it stops collecting data. Nevertheless, this is a very cost-effective thing to monitor patients who have very fluctuating blood, highly fluctuating blood glucose level. It comes as a cost within 2,000 rupees. The sensor costs just around 2,000 rupees, and it's available online as well. This is a CGMS, which is a continuous glucose monitoring system. Again, now, what is the point of just monitoring, and what is the point of just delivering insulin, and what is the point if somebody is on insulin pump to use a glucometer to monitor? So these issues have led to the integration of CGMS system in a insulin pump. And insulin pump is such a beautiful tool which actually gives patient freedom. Patient does not have to inject insulin multiple times a day. He just has to use a pump which is attached to his body all the time. The insulin is filled up at intervals. The dose of insulin delivery is adjusted based on how much carbohydrates the patient is going to take. Of course, the patient has to learn about carb counting. And the CGMS actually is integrated in the insulin pump in the latest devices, which even guides how much dose can be delivered. So in coming years, we can have more sophisticated devices The one which we have now is good enough, but we can expect better devices in the coming years. This is how the insulin pump looks with the integrated CGMS. And I would also like to add about InsuPort. There are people who have to take insulin 3 or 4 times a day, and they have to keep injecting at different sites. So now we have something called InsuPort, which is to be attached to the skin and changed every few days. So patient does not have to prick the skin. The port inserted once stays with one end in the subcute tissue. So when you inject insulin in the port, it doesn't pierce your skin, but it delivers the insulin to the subcute tissue. It is called InsuPort. I'm sorry, I forgot to put the picture of InsuPort, but that is also an option available for patient on multiple daily injections of insulin. I guess we have covered everything about insulin. And thank you so much for having us here.
I have questions.
If you have any questions, please ask.
Now I request to all participants for ask any query or any questions. Also, you can post your questions in the chat box also. Yes, if anyone have any question, please you can ask. Rutvi, you raise your hand. You have any question?
No, ma'am.
Okay, thank you, Rutvi. Thank you both, madam, for sharing and enlightening and your abundant knowledge. Thank you both of you for taking a time out of your day to join us for this conversation. Thank you very much, madam. You both.
Thank you so much.
Thank you.
Now it's time to display the results of essay competition. So I would like to invite Dr. Jyoti Manali ma'am to share with us the information that students have written in the essay of diabetes.
Okay, my few comments on the essays that have been written by the students. Uh, One, that when you are asked to write an essay, you gather material from the net is okay, but you have to put it in your words. There are people who have directly copied from the net and put it on paper and given it to us. All of us realize that some things you have to collect from the net, like epidemiology, prevalence, etc. That is fine, that we are not against. But the point of giving you this topic was the role of nurses that is expected in diabetes management. Okay, so when we are wanting you to write on this, you should have some ideas. One of the student has given some creative ideas, like something can be done for the school going type 1 diabetics. Some people have written about nursing care for pregnant ladies. That is correct. These are all to be put. But if your data contains only material that you have gathered from the net, we have not marked you good. So whenever you are asked to write an essay, there should be some originality in whatever you are writing. So that is the first thing which have that is called creativity. So we have given maximum marks for creativity. Some marks go for the language, some on highlighting the theme that is highlighted. So you can have some detailing on what are your ideas on how patient education can be bettered by your nurses. This is what was the aim. So now the results, of course, Shiny Madam will announce.
Thank you very much, madam, for your sharing your experience. And now it's time to display the result of intercollegiate essay competition on the theme Diabetes and Nurses Make the Difference. The first rank is goes to Adrumi Patel from Shri G.H. Patel College of Nursing. And second number is goes to Dhruv Patel. He is also from Shri G.H. Patel College of Nursing, a constitute of Baikaka University, Karamsad. Your e-certificate will be provided by your email ID.
Now, I request to all participants, the feedback link is available in the chat box. So I request to all participants to fill your valuable response, and it's also available in the YouTube live streaming. Also, you can post we post on the YouTube chat box. Thank you very much, all of you. I would like to express my heartful gratitude to all of you who sincerely committed to this event to make it a successful. Now we are at the end of this program. This event would have been impossible without the support of each and everyone present here. Thank you for your valuable presence, and sorry for any inconvenience. Now I would like to invite Miss Saini for vote of thanks.
Thank you, Disha madam. On behalf of Sri G.H. Patel College of Nursing, Karamsad, I take this opportunity to propose vote of thanks to those who have directly and indirectly contributed to this webinar. At the onset, I would like to thank our resource person, Dr. Jyoti Mandari ma'am and Dr. Poonam Bhinde ma'am. We are really enlightened with your knowledge, ma'am, and your presence. I would like to also thank Ms. Anna Rao and Ms. Nikita Chauhan ma'am for also sharing their knowledge on diabetes. I would like to thank our principal ma'am, Mrs. Raksha Parmar, for her enthusiastic support. A special thanks for the organizing committee, teaching and non-teaching staff for their support and coordination. I would like to thank Sunny Sir, nursing tutor, Sri G.H. Patel College of Nursing, for his constant support in this technical work. And lastly, my heartful thanks to our students for the active participation. With these warm words, we move to the end for today's webinar. Thank you.
Wishing you a great health in coming life. Stay happy, stay healthy. Once again, thank you, all of you.
So glad you could actually deliver the talk. The technical